Hello, my name is Christina Miyawaki. I'm an associate professor at the University of Houston Graduate College of Social Work. Today, I'd like to present one of the papers I worked on during my Texas RCMAR Scholar Year between 2020 and 2021. It is called The Association Between Caregivers' Characteristics and Older Care Recipients' Well-Being Among Vietnamese Immigrant Families in the United States. I conducted this study mentored by Dr. Kyriakos Markides at the University of Texas Medical Branch at Galveston. So after the fall of Saigon in 1975, many Vietnamese refugees arrived in many cities in the United States. They arrived in 3 different waves from 1975 through the 1990s. Vietnamese Americans constitute the 6th largest foreign-born population and 4th largest Asian origin subgroup. Its number is over 1.3 million people, and the vast majority moved to San Jose and Los Angeles in California and Houston and Texas. So due to their low socioeconomic status and limited English proficiency, research on this population hasn't been done much. However, limited study shows that the health of Vietnamese immigrants and refugees was poor compared to other racial and ethnic groups. Some studies found that there is a high prevalence of depressive symptoms among Vietnamese people of all ages. Health studies of Vietnamese older adults and their caregivers hasn't been undertaken. Houston hosts the 3rd largest Vietnamese population in the US, and its number is more than 81,000 people. Some studies said it's more than 120,000 people. Vietnamese population is the largest Asian subethnic group in Houston, Texas, and their number is still growing. For Vietnamese people, Houston is an ideal place because of the similar warm weather, an expanding economy, and cost of living is less expensive compared to the San Francisco and Los Angeles areas. So the first Vietnamese immigrant arrived in the US in 1975. So this year is 2022, more than 45 years ago. So many Vietnamese people get older and may need assistance in their daily living activities. However, there is no data on the health of Vietnamese older adults and their caregivers, and there is no knowledge of Vietnamese elder caregiving practices. So we decided to create a survey and investigate how these Vietnamese older immigrants and their family caregivers are doing. So we created 3 different surveys, one for adult-child caregivers, another one for spousal caregivers, and the 3rd one, Care Recipients survey, meaning for Vietnamese older adults in English and Vietnamese. Using the study flyers in English and Vietnamese, we collected their health data in 2018, and we are able to collect 199 surveys. As mentioned earlier, we created 3 different surveys. For caregiver surveys, we included caregiver sociodemographics, global and psychological health, which include caregiver burden, perceived stress, positive aspects of caregiving, and relationship with the care recipient, social service use, social support, and sense of filial responsibility. For the care recipient survey, we measured the care recipient sociodemographics, health problems, ADL, IADL independence, memory problems, social service use, social support, and filial responsibility expectation. For inclusion criteria, caregivers must be either an adult child caring for a parent who is 65 years and older, voluntarily, or spouse caring for a spouse who is 65 years and older, or paid caregiver. But for this study, we did not include paid caregivers. For care recipients inclusion criteria are care recipients must be 65 years and older, self-identify as Vietnamese, they speak English or Vietnamese, and they live in Houston at the time of the survey. For data collection, we established rapports with Vietnamese social service agencies from 3 to 4 years prior to conducting the survey. We hired several Vietnamese bilingual and bicultural research assistants, and we used study flyers in English and Vietnamese and snowball sampling and word of mouth widely. We recruited participants through Vietnamese community gatekeepers from Vietnamese social service agencies, Vietnamese senior housing, and Vietnamese faith organizations. We also provided a monetary incentives as a store gift card of $20. We measured caregiver care recipient sociodemographic data that's included age, gender, marital status, education years, employment status, and caregivers' caregiving related variables included duration and intensity of caregiving. For care recipients' health, we measured ADL, IADL independence, depression, which was measured by the 20-item CST. We measured care recipients' cognitive function using MMSE, and caregiver burden was measured by the Zaret burden interview, which is a 12-item instrument with a 5-point Likert scale. So based on this data set, the purpose of this present study was to examine if caregivers' psychological and social contextual backgrounds are directly or indirectly associated with the care recipient's mental health. So this is the conceptual model of the study. So we use caregiver burden as a psychological background, education years and employment status as caregivers' social contextual background, and care recipients' age, gender, activities of daily living, and the result of their mini mental state exam as covariates. The dependent variable was the result of care recipients' mental health, which is their depressive symptoms. We use means and standard deviation for continuous variables and frequencies and proportions for categorical variables. We use chi-square and t-test for comparison between adult-child and spousal caregivers. We use logistic regression model to find the association between caregivers' characteristics and care recipients' depressive symptoms. We started with model 1, which is caregiver burden as a crude model. For model 2, we added care recipients' demographics, health-related characteristics, and cognitive function. For final model, model 3, we added caregivers' education years and employment status. This is the result of the characteristics of caregivers and care recipients. Due to the time constraint, I will explain the significant results only. The total sample size of this study was 116 surveys, which is a total of 58 caregiver care recipients diets. Caregivers' mean age was 53 years old, ranging between 21 and 82 years old. And 97% of them were born in Vietnam, and they immigrated at the age of 32 years old on average. Their education years was 10 years. Care recipients' mean age was 75 years old and ranging between 65 and 90 years old. And 100% of them were born in Vietnam and immigrated around the age of 51 years old. Their average education years was 6 years. So continuing their characteristics. The majority of caregivers' self-rated health was good or excellent. Their caregiving hours were on average 20 plus hours per week, and their caregiving duration was 7+ years. 84% of them co-resided with their care recipients. For care recipients, they self-rated their health as fair or poor. 40% of them are clinically depressed, and 21% of them had cognitive impairment. So now, Table 2 shows the result of logistic regression, predicting care recipients' high depressive symptoms. In Model 2, adjusting for care recipients' demographic and health factors, the number of ADL independents was significantly associated with lower odds of high depressive symptoms. Care recipients with cognitive impairment experience more than 5 times and 8 times greater likelihood of reporting high depressive symptoms compared to those with no cognitive impairment. Care recipients with more independent remained less likely to report high depressive symptoms. In Model 3, the relationship between burdened caregivers and care recipients' depressive symptoms became statistically significant. Care recipients who are cared for by burdened caregivers are significantly less likely to report high depressive symptoms. So we found that when the caregivers are burdened, the care recipient reported fewer depressive symptoms, which was a surprise. However, this pattern is supported by Holman's social exchange theory. Social exchange theory posits that interaction between persons is an exchange of goods, material, and non-material. And our social behaviors often resonate and are assembled by the exchange. Social exchange perspective includes the physical, social, and psychological exchange of subjective goods. For example, if care recipient helps caregivers with their chores, or care recipient become a helpful company to caregivers while receiving their care, or care recipient making caregivers feel useful is an exchange of goods or non-materials. So when care recipients exchange the social good by playing a helpful company role, by being a good company when their caregivers care for them, eventually benefited the care recipients. Care recipients brought an exchange of a balance in the care relationship with caregivers and reduced caregivers' care burden. By doing so, care recipients felt better and showed fewer depressive symptoms because care recipients may not feel that they are burdening caregivers as much as just receiving care. There are some strengths of this study. This study used dyadic data, which is rarely done, and we focus on an understudied population, Vietnamese immigrant. So for future studies, we recommend using a larger caregiver care recipient dyad data and examine the relationship longitudinally. However, there are limitations of the study as well. So first, this is cross-sectional data with a small sample, and therefore, no causal relationships can be predicted, and it requires caution when interpreting the findings. Because it is a small sample, the result cannot be generalized. Also, these associations can go from both ways, from caregivers to care recipients, and from care recipients to caregivers. So we found that many Vietnamese families live in multi-generational households within ethnic enclaves and remain the tightly knit family unit. They showed resilience to their low socioeconomic status. Therefore, leveraging a family as their strength, healthcare professionals should take a caregiver, care recipient dyad approach when planning intervention studies with Vietnamese communities, especially under the COVID-19 pandemic. So now I would like to acknowledge my Texas RCMAR funding here. And this paper has been recently published in the Journal of Community Psychology. My co-authors are Dr. Mingwei Liu from the Central South University in China and Dr. Kyriakos Markidis from the University of Texas Medical Branch at Galveston. So thank you very much for listening to the presentation. All of the references are listed in the slides 27 and 28. Thank you very much.